all of you once again. Welcome to the teaching session of Department of Urology, Savai Mansingh Medical College, Jaipur. So today we have a teaching session on lower urinary tract trauma. This will be presented by Dr. Naveen and would be moderated by Dr. Vinay Tomar. And today's expert faculty is Dr. Sunil Gokru. Dr. Sunil Gokru is a SMS alumni only, and presently he is the professor and head of the department at R&T Medical College, Udaipur. So welcome, Dr. Sunil, and welcome to our teaching session. And now I would request Dr. Vinay Tomar, if he's there, to kindly moderate the session and invite the presenter. Or Dr. Naveen, if Dr. Tomar is not there, go ahead and present the session, please.
Yes, sir. Good morning, respected teachers and dear colleagues. Today's topic is lower urinary tract trauma. First introduction, it includes bladder and urethral injury. Most common causes are vehicular accidents and iatrogenic. First, we will talk about injuries to urinary bladder. It constitutes less than 2% of abdominal injury that requires surgery. It can be extraperitoneal, nearly 60%, intraperitoneal, nearly 30%, or both. Etiologies are blunt trauma, usually associated with pelvic fracture or penetrating injury like gunshot, or iatrogenic injury like gynecological, pelvic, or transurethral surgeries. First, extraperitoneal injury, pelvic fracture by blunt trauma leading to perforation and extravasation of urine in the extraperitoneal space, and the high risk factors here will be pubic rami fracture, more than 1 centimeter pubic diastasis, and if urine gets infected, it turns into abscess, and the symptoms will be gross hematuria, lower abdomen and pelvic pain, and inability to pass urine. The signs will be lower abdominal tenderness and hemorrhagic shock. Intraperitoneal rupture will be secondary to blow, kick, or fall with full bladder and usually near the dome. If urine is sterile, there will not be any immediate peritonitis symptom. But if urine is infected, there will be immediate peritonitis. Symptoms will be sudden agonizing pain, syncope, non-passage of urine since trauma, lower abdomen pain, and fullness. The signs are abdomen fullness, tenderness, rigidity with shifting dullness, and bulge feeling on rectal examination. These are diagrammatic representation. Left side is extraperitoneal and right side is intraperitoneal rupture. This is AAST organ injury scale for bladder injury. First one is hematoma or laceration. If hematoma is there, then it is contusion and intramural hematoma, and if laceration, it is partial thickness. Grade 2, it is laceration of extraperitoneal bladder wall, but less than 2 centimeter. Grade 3 is laceration of extraperitoneal more than 2 centimeter or intraperitoneal less than 2 centimeter. For grade 4, it is intraperitoneal and more than 2 centimeter, and grade 5, laceration extending into the bladder neck or urethral orifice. Investigations needed: X-ray pelvis for pelvic fracture, and for intraperitoneal rupture, there will be ground glass appearance. Ultrasound abdomen and pelvis can show free fluid and other injuries along with the catheter bulb position. Next is RGU and MCU, mainly in drainage film. It will be seen, and leakage of dye can be in extraperitoneal or intraperitoneal region. And IVP and CT scan. CT scan is most sensitive and specific. It will also inform about the other organ injuries. Left side is extraperitoneal rupture with teardrop deformity and flame shape, and right one is intraperitoneal rupture with dye going intraperitoneally. Complications will be pelvic abscess, delayed peritonitis, and partial incontinence if associated with bladder neck trauma and not repaired. And emergency treatment is start with resuscitation and management management further will be as per the type of rupture and associated injuries. For extraperitoneal rupture, most cases are managed with catheter only, but there are few indications for surgery. And those are bony fragments projecting into the bladder, open fracture associated with rectal perforation or vaginal injury, and bladder neck injury. For intraperitoneal rupture, it will be managed surgically and with suction of all urine and repair in 2 layers with placement of SPC. For pelvic hematoma and fracture, simultaneous packing and stabilization can be done. Post-op management includes IV fluid, antibiotics, and to keep the catheter patency maintained. For penetrating injuries, immediate exploration is advised. Next is blunt trauma during open surgery. Prevention will be by pre-op placement of periurethral catheter. If recognized at the time of surgery, it should be closed in 2 layers and placement of catheter should be done. If there is extraperitoneal rupture with large fluid accumulation, it's better to place drain. And for intraperitoneal rupture, laparotomy is required. These are EAU recommendations. Perform cystography in presence of visible hematuria and pelvic fracture. That is a strong recommendation. Perform cystography in case of suspected iatrogenic bladder injury in post-op setting. Again, a strong recommendation. Perform cystography with active retrograde filling of the bladder with dilute contrast up to 300 to 350 ml, and perform cystoscopy to rule out bladder injury during retropubic suburethral sling procedures. Manage blunt extraperitoneal bladder injuries operatively in case of bladder neck involvement and other associated injuries that require surgical intervention. Manage blunt intraperitoneal injuries by surgical exploration and repair. Perform cystography to assess bladder wall healing after repair of a complex injury in case of other risk factors involved. Now coming to injuries to the urethra, this is more common in men with pelvic fracture or straddle trauma, and the most common sign here is blood at meatus. First, posterior urethral trauma. Pelvic fracture is associated with 10 to 15% urethral injury, and the most common sites involved will be membranous urethra and bulbomembranous junction. Direct blow with butterfly fracture causes less gap than when injury occurs from front to back on one side with pubic and ischial rami fracture and sacroiliac joint disruption. Another cause is shear trauma. It can be complete or partial. The symptoms will be perineal and suprapubic region pain, inability to pass urine and blood at meatus. The signs will be suprapubic tenderness and displacement of prostate on DRE and pelvic hematoma. And after initiation of shock and hemorrhage management, we need to assure the type of injury and drainage of urine. Cystourethrogram is advised before attempt of periurethral catheterization. SPC placed and maintained for 6 weeks to 3 months before further RGO, MCU, and further repair. Partial tear is healed spontaneously, and here RGO and VCUG can be done earlier, that is within 3 to 4 weeks before further management. And another option is primary alignment endoscopically and open. Endoscopic method is good for partial tears, and here stenting of gap will be done with catheter, but it is advised only in stable patient. Open method is difficult and more bloody. Cystostomy is done, and the railroading technique will be applied for placing catheter over guide wire. 6 weeks later, RGO MCU is done, and if no leak is there, catheter can be removed, but high chances of stricture development will be there. Delayed reconstruction is advised after 3 months after getting exact length of stricture by RGO and MCU. This is a management protocol by EAU. For posterior urethra injury, after assessing hemodynamic stable, if patient is unstable, then after resuscitation, we need to divert the urine either by one gentle attempt of urinary catheter or suprapubic catheter. But if patient is stable, first we have to perform retrograde urethrography or urethroscopy, and if the injury is partial, we can go for early endoscopic realignment, which if failed, then suprapubic catheter is placed and further follow-up will be there. In case of complete if there is injury to bladder, neck, and prostate, then we need to go for early repair. If it is not, and a patient is undergoing surgery for some associated injuries, then we can think about early endoscopic realignment. Otherwise, SPC will be placed. And there are some indication where we can go for early urethroplasty, that is short distraction defect, soft perineum, and lithotomy position if possible for patient. The indication of early urethroplasty, as I said, the prerequisites are short restriction, soft perineum, and when lithotomy position is possible. The conditions where early urethroplasty is indicated is bladder neck laceration with posterior urethral trauma, as it never heals spontaneously and incontinence chances are higher. Now coming to anterior urethra, mostly isolated and commonly involves bulbar urethra. The causes will be are perineal blow, to fall astride on projecting objects, cycling maneuver, manhole covers, and gymnasium accidents. Self-instrumentation is also one cause. Penetrating injury and gunshot injuries can also cause anterior urethral trauma, and contusion and laceration both are possible. The symptoms triad are urinary retention, perineal hematoma, and bleeding from external urethral meatus. Rectal examination reveals normal prostate. If ignored, it can lead to massive extravasation with necrosis in the perineum and fistula formation. Further decision is taken considering clinical feature as well as ICUG both. This is diagram showing anterior urethral trauma. And if there is contusion and urethral continuity is maintained, patient is voiding well, and no blood in urine will be there, then conservative management without catheter can be done. If contusion is there, continuity maintained, but bleeding is present, then catheterization is advised. For laceration, SPC is advised, followed by RGMC after 4 to 6 weeks. Depending upon degree of laceration, healing may lead to stricture formation here. Delayed reconstruction is advised if needed, as immediate reconstruction can lead to bleeding, infection, and stricture formation. For smaller strictures, OIU can be done, and for penetrating injuries, immediate repair is advised. This is management protocol of anterior urethral injury. It can be iatrogenic, blunt, penetrating, or penile fracture associated. For iatrogenic and blunt trauma, either partial or complete, urinary diversion in form of urethral or suprapubic catheter is advised. If it is partial, then after 1 to 2 weeks, and if it is complete after 3 weeks, we can go for ureterogram and further follow-up. For stable penetrating injury and penile fracture, immediate repair is advised. This is AST injury grading of urethra. First is contusion, that is blood at urethral meatus. Second is stretch injury, that is elongation of urethra without discontinuity. Third is partial disruption, that is extravasation of contrast, but dye still reaching urinary bladder. Fourth is complete disruption, that is extravasation of contrast, but the length will be less than 2 centimeter and dye not going into the bladder. Fifth is complete disruption, where the transaction is more than 2 centimeter and dye is not going into the bladder, and also when it extends into prostate or vagina. This is diagrammatic representation of the scene. The complications will be bleeding, infection, necrosis and fistula formation, stricture formation, erectile dysfunction, and incontinence. Follow-up advised up to 1 year with uroflowmetry, cystoscopy, or RG. These are EAU recommendations. Provide appropriate training to reduce the risk of traumatic catheterization, and evaluate male urethral injuries with flexible cystourethropy or retrograde urethropy. Evaluate female urethral injury with cystourethropy and vaginoscopy. Treat iatrogenic anterior urethral injury with transurethral or suprapubic urinary diversion. Treat partial blunt anterior urethral injury by suprapubic or urethral catheterization. Treat pelvic fracture urethral injury in hemodynamically unstable patient by transurethral or suprapubic catheterization initially. Do not repeat endoscopic treatment after failed realignment for male PFUI. Treat partial posterior urethral injury initially by suprapubic or transurethral catheter. Do not perform immediate urethroplasty in male PFUI. Manage complete posterior urethral disruption in male PFA with suprapubic diversion and deferred urethroplasty. And in case of female PFUI, perform early repair. These all are strong recommendations. Now coming to female lower urinary tract trauma, first bladder injury during mid-urethral sling surgery, approximately 5% chances are there, and it should be managed with reinsertion and catheterization. For urethral injury, great inherent elasticity and flexibility provided by the vagina. These are the predisposing factor for urethral injury, and the causes are pelvic fracture, birth injury, and suburethral sling surgeries. It can be of two types, that is, first is longitudinal or partial, which is more common. And second is transverse or complete. Concomitant injuries are bladder and vaginal injuries, leading to high chances of incontinence and urethrovaginal fistula. Pelvic fracture with blood at introitus necessitates vaginal examination for laceration and labial swelling. And here urethropography is difficult due to short urethra and vulval edema. So urethrooscopy and vaginoscopy is advised. Early repair is advised as chances of incontinence and vaginal stenosis are high on delayed repair. For proximal urethra, retropubic route is advised, and for mid urethra, transvaginal route is advised along with simultaneous vaginal repair. Thank you, sir.
Thank you, Dr. Naveen. Do we have Dr. Tomar with us?
Sir, I have called.
Yes,
Okay.
I'm with you. I'm
Okay.
listening.
Okay, fine. So you can just invite our expert faculty today, Dr. Sunil Gokru, and if necessary, you can give your own comments, please.
Dr. Sunil Gokru, can you hear me? He's online?
Yeah, he's online. Yeah.
Gokru?
Yes.
Yes, sir.
Any comment regarding primary or delayed repair? Any comment?
Sir, he has covered topics very nicely. So at present, there is nothing left for us.
To say.
Okay.
Well, he has covered all the aspects. Huh?
As per trauma, yes, sir.
But in my experience, I have seen that in female fracture pelvis, we have never come across any primary repair. We always follow delayed repair, and very few occasionally we did it. Anybody has experience?
I think yes.
In female patient, especially.
Yeah, in female patients, usually when there is a urethral injury, there is a vaginal injury also, and what is recommended is that you should try to explore catheterize if possible immediately. Otherwise, if you're not trying to explore and catheterize it, there is a chance that the whole urethra will get fibrosed if you just put a suprapubic in female patients. So it is recommended that you do an early kind of realignment if possible and try to find the urethra. So that is usually the recommendation, unlike the male urethral injury where we usually put a suprapubic cystostomy.
I had come across a patient, female patient. In that case, bone was impacted against the urethra after fracture. So we have to do transpubic removal of the bone, and then got aligned, urethra got aligned. She's still voiding, and she has become a doctor.
Very important that
very rarely we find such injuries.
Yeah. So even if there is no bony spicule in the urethra, usually they would cause vaginal injury, and immediate catheterization, if possible in any way, should be attempted. That's the usual recommendation. And secondly, I think about the trauma, doing a urethrography, I have spoken to many of those stalwarts for bladder and urethral injury. They are almost not doing a routine urethrography in the emergency. So what we are doing nowadays is a flexible urethrooscopy. A very gentle, flexible urethrooscopy is probably what most people would recommend. And if you find that you cannot pass a flexible urethrooscope and cannot pass a guide wire across, so then probably what you require is a suprapubic cystostomy, and there should not be any attempt on catheterization. Any comment from any other faculty member or residents? Do you have any query? So another important thing is about the pediatric injuries. Similar to the renal injury in children, bladder injury would be more common in children and that would be more kind of a severe injury because of its intraperitoneal location of the bladder. So in children, it is usually located intraperitoneally, so the chances of bladder injury are more in children. So that should always be remembered.
Also, chances of bladder neck injury is more in children.
Yeah. So children are more prone to both bladder and renal injuries. Any other comment from anybody?
Sir, I would like to make a few comments, sir.
Yeah, please go ahead.
So from the exam point of view, sir, just for the benefit of the residents, as far as a primary realignment endoscopy goes, I think that as I think majority of centers are not doing that, and even if they don't tell that inside the exam, so I don't think that that is going to be a problem. This is because majority of people, even those people who are doing dedicated urethroplasty, don't get a chance to do a primary endoscopic realignment. He made a comment about railroading. I think that railroading is absolutely not indicated, and railroading should not be done. It should not be confused with primary endoscopic realignment, because railroading would be a blind technique once the patient, if he is undergoing any concomitant exploration of the pelvis, then also the realignment that should be done you should try to do it endoscopically. And even inside the guidelines that he gave, there was no mention of a railroading and open whatever mention was inside the guideline only was endoscopic realignment. But if they are given inside the exam and they are asked about it, then if they forfeit that we are not doing it and we've not seen it, then I don't think that that is a major issue. This is because majority of centers, even worldwide, they don't do it. So one point is that. Number two, as far as pediatric urethroplasties goes, pediatric urethroplasties, they are very more simpler to do with adults because the pubic symphysis is not that calcified and it has got more of fibrous tissue. So doing a pubectomy inside children is easy, and you can also do an extended pubectomy, and very rarely you have to go transpubically in children. This is because from below you can get a good wedge of the pubic symphysis, and you can also do an extended pubectomy in children very easily because it's not as calcified as that of adults. These are the 2 points that I want to make. And as far as emergency management, even if they inside the exam they say that I'd like to do a gentle attempt at catheterization, they don't have the facilities of doing RGU inside emergency, and they just want to put a SPC. Just from the examination point of view, I think that they can stick to these things. This is because whatever it comes inside the guidelines and books, sometimes practical issues are always there and they're not able to do all those things, and it doesn't make it wrong. Actually, this is just what I wanted to add.
Yeah. So yes, so as I said, most of the centers do not do a routine ureterogram nowadays. Instead of, if you want to do a flexible ureteroscopy, so that is usually done. About the railroading, the only probably indication would be when you are doing an exploratory laparotomy and then there is associated urethral injury, then you might try even putting a catheter by kind of this railroading technique. That is probably the only indication. Otherwise, even if you want to do a railroading, it has to be done endoscopically. So by flexible endoscope, that is what is the recommendation. When we are talking about the lower unit tract injury, there are, there could be even genital injury. It could be testicular injury also. So if you're talking about genital unit trauma, we should always think of penile injury, fracture penis. Sometimes trauma to the penis can cause a flail penis if the suspensory ligament is injured. Sometimes there is injury to the dorsal vein and artery, can mimic a picture of fractured penis. And then testicular rupture is also possible with the blunt trauma to the genitals. And they are also graded and accordingly. So I think we should know a little bit about the genital injury when we are discussing about genital unit trauma. So I think we would, if there is no other query, no other comment from any of the faculty member, I would request the moderator, Dr. Vinay Tomar, to kindly give a vote of thanks and give his last comments, please.
I
सर
thank
वो
Sushil.
सर वो सबके वीडियो बंद कर रखे हैं, ऐसा लग ही नहीं रहा है कि क्लास में सारे वीडियोस उन्होंने ऑफ कर रखे हैं.
Okay.
वीडियो
Okay.
इसलिए कर रखे कि Dr. Sunil, thank you very much.
Is it from my side? I don't know. Yes, now it is okay, no?
नहीं सर, हमारा तो अभी भी अब हो रहा है सर. ऐसा लग ही नहीं रहा था कि we are in class.
Okay, okay. There was some problem with, maybe it was my mistake. I don't know whether it was from my side or from the Nimesh's side. I don't know.
Sir, everybody
Anyway.
can नहीं सबका वीडियो ऑन था सर. मतलब
Okay,
they
okay,
can
fine.
open.
Okay,
इसमें
okay,
लिखा होगा
fine.
host has stopped. इसमें लगा you cannot start your video because the host has stopped it.
So maybe there may be some technical fault. Anyway, so Dr. Gokru, your last comments, please.
Sir, regarding that, Tomar sir has told about the female trauma. Generally, we don't get such patient at the time of trauma. So
Yeah.
probably sir is right. We do it usually later stage, on the later stage.
Right. The point is, if you find there is a fracture pelvis in females, and if you find a vaginal injury, urethral injury, you should try to just do an exploration and find the urethra if possible. So that was the only comment that was made. Anyway, so thank you, everybody. Thanks, Dr. Sunil, for coming to our teaching session. Thanks, Dr. Vinay Tomar, for moderating the session, and all faculty members and residents. Thank you very much. Have a good day.
Thank you. Okay, same to you.